available on the official PsychSign YouTube channel for everyone to see afterward, if you do want to reference it, or maybe you have a friend that wasn't able to make it. So we are fortunate enough to have people from every single practice, meaning family medicine, internal medicine, neurology, and we also have a panelist that's from a triple board program. So the way we envision this is we want to start off with introductions and really just getting a sense of why our panelists chose this career path in particular. And then the later half of our session today will be focused around Q&As from questions that everyone submitted before the session. So just to start, if we could just go around and have our panelists introduce themselves, talk a little bit about where you are in your career, where you trained or where you're currently located, and why you felt that sort of this structure, this type of training was right for you. And along that, feel free to drop any pearls of wisdom. We do have about 8 to 10 minutes per panelist, so definitely take your time. Whoever wants to go first, I more than welcome it.
Sebastian, it might go more smoothly if you just call out the panelists and we can go in order.
Got it. Okay. So Dr. Abraham, do you want to start us off?
Sure. I can definitely start off. So my name is Rohit Abraham. I'm one of the fourth years at Boston Medical Center in the Family Medicine Psychiatry double residency. And I guess I started off thinking I was like trying to figure out a path between like medicine and non-medicine things. Like even in undergrad, I was pretty invested in social justice and wanted to figure out like how to incorporate that into my career, whether that was medicine or not. And so I did a stint with Teach for America, and I was a public school teacher teaching ninth grade biology in Detroit Public Schools. And I did that for a couple of years and then transitioned into a position in AmeriCorps with a homeless shelter in the Detroit area. And then that was the year that I applied into medical school, started medical school, and really wanted to like embrace like, you know, public health and social determinants of health as part of what I wanted to do as a physician, and use like my position as a physician more as like a platform to address a lot of those things. And so, you know, going through medical school, as always, is like really, it's a tough situation, right? You're always like focused on like molecular, very individual perspective things. And I was really interested in more broad things. And so I did end up taking a year between my third and fourth year where I did a master's in public health, found that to be incredibly helpful and incredibly enlightening for like what I wanted to do more longer term. I was really fortunate to be able to do that at the Harvard School of Public Health while I was at the Michigan State University College of Human Medicine. And then that really also gave me a lot of time to think about what specialty I wanted to do. I spent a lot of time thinking about and talking with people who are doing combined FM and psych work, because at that point I'd finished my rotations. FM was my first rotation, psych was my last rotation, and I was like, dang it, I didn't really expect to love psychiatry, but like that happened. So now I was kind of trying to reconcile those things. So I got introduced to the AMP, the Association of Medicine and Psychiatry, which Dr. Gagliardi, I'm sure, will let you know more about. And I also got to talk with a lot of other people, do an away rotation at UPMC, University of Pittsburgh Medical Center, during my fourth year. And that really all solidified my decision to kind of pursue combined training. I decided to go the family medicine psychiatry route instead of the internal medicine psychiatry route because I was more interested in working outpatient at the end of the day. I had interests in doing termination care, and I really like working with children, and I didn't want to like pull those things out of my overall general practice. And so that's sort of like the personal factors that motivated me to choose FM Psych. But the overall sort of grounding reason that I wanted to pursue both residencies instead of like just one or the other was that I'm really, really interested in providing very broad spectrum addiction care. And whether that's addiction medicine or addiction psychiatry, I'm still more likely going to end up doing like an addiction psychiatry fellowship on top of the residency, but I definitely don't think that's required clinically. I think if you come out of almost any of the combined programs, you're going to feel very solid in addiction and like really able to treat almost anything you come across. But I am interested in the fellowship for research reasons and other things. And so I'm going to probably end up doing that after residency. But all that said and done, being able to address someone's physical comorbidities, someone's mental health comorbidities, and their addiction comorbidities all in like one combined visit is an incredible vision that I hope to kind of bring forward for my patients, especially because that plus therapy would be like 4 different visits a week, maybe, in a single week for some people, which is really hard with the social determinants of health we're always trying to address. Really, like longer term, I'm interested in becoming a training director for family medicine psychiatry in the future. And I'm also thinking about doing some public health things, like working at a city or state health department for either physical or mental health, maybe both. We'll kind of see how that leads on. So I guess that's probably it for my rambling for the time period. You want to go ahead and switch to the next speaker?
Awesome. So I think that's a perfect transition. Dr. Gagliardi, do you wanna go next?
Sure. Hi, everybody. I might be on the opposite spectrum of Dr. Abraham. I guess I'm a PGY 25 this year. I am currently the residency director for the Duke Combined Program in Internal Medicine Psychiatry. And I too could tell a really compelling story about the importance of holistic and comprehensive care of human beings as the underlying reason that I have chosen to do combined training and have focused my work on sort of combined areas in the overlap. I finished medical school here at Duke in 1998. I had an advisory dean who was the psychiatry training director who had co-founded the combined med psych program. She was my advisory dean too. So she suggested I apply in med psych. I applied in both medicine, psychiatry, and internal medicine programs, and solidified my desire to do combined training when the advisor in medicine suggested that I could do a medicine residency and read a book about psychiatry. And then I thought, I am doing combined training for sure. It was a long, it's a 5-year training program. And to Dr. Abraham's point, to do research, I think this was one of the questions that I had seen in your very thoughtfully prepared questions. There's really not a lot of room for protected time to do anything that's truly protected, although a lot of our residents manage to do quite a few inspiring things despite that. So it's a long 5 years. It's intense, going back and forth between one specialty and the other. And over the course of the last couple of years of training, you really developed, not just expertise in internal medicine or expertise in psychiatry, but you become a physician who can't see a patient without seeing both. And so for me, I practice on our general medicine service 4 weeks out of the year, the academic gen med service with residents and students. I practice sometimes on our inpatient psychiatry service. I do some psych consult work. For these 3 weeks, I'm in our psychiatry emergency department, where I find that my medical knowledge and ability to recognize that, I don't know, panic attacks don't really last, 45 minutes and have associated EKG changes. Maybe we need to think about angina or a different reason for these symptoms. Helps me advocate for my patients in a very strong way that I would honestly recommend for anybody going into behavioral health, because our patients can be marginalized or stigmatized based on their presentations and other kind of intersections of their identities. I have gravitated towards educational opportunities. So I was the medicine clerkship, sub-internship, and sort of undergraduate medical education director for about a decade. I was associate program director for psychiatry, and then for 6 years, residency director in psychiatry. And since 2019, I've been the residency director in the combined med psych. And I've also had a passion for quality improvement, health equity, patient safety, and different opportunities in my health system. I'm the chair of the neuroscience formulary evaluation team, and use that opportunity to say, well, why can we pay $500,000 for a year of chemotherapy and we can't approve $1,000 a month for a tardive dyskinesia medication? And so I find that the combined approach to people and systems is really very useful and helpful. I don't want to, nobody needs my whole biography, but if anybody wants to reach out to me with questions at any time, jane.gagliardi@duke.edu is my email. As Dr. Abraham mentioned, I am one of the past presidents of the Association of Medicine and Psychiatry. I've given Sebastian a couple of links because they have an upcoming residency fair that's virtual this year. So it's kind of low stakes. And I think we managed to advocate for it to be free for medical students. So if you're in your 3rd or 4th year and you're like, who are these program directors and would I even care about what they're doing? I'd strongly consider going to that residency fair. There's also an annual meeting that is not free and is in person in Atlanta towards the end of September. And I think that's probably enough out of me, Sebastian. Thank you.
Great. Thank you so much. Any links and any associated information, we'll be sure to send that in our next PsychSign newsletter, just so everyone can get it in their email. And yes, the recording of this panel will be uploaded to our official YouTube channel for you all to see and reference as needed later on. So our next panelist, I want to let Dr. Wakimoto introduce himself. Thank you so much.
Hey guys, my name is Yuji. I'm one of the fourth-year residents at the University of Utah Triple Board Residency Program. I think the first thing that people tend to have questions about is what 3 boards are included in the Triple Board. And so just to clarify, it's general pediatrics and then adult psychiatry and child and adolescent psychiatry. So the adult and the child psych boards count separately, which is where the 3 boards come from. I went to Stony Brook for med school, just like Alan. We were actually classmates starting off. Alan did the smart route, doing the MD PhD program. So, and then I think as I went through med school, I was always interested in more pediatrics. I thought I was gonna do something related to like kids and adolescent health and stuff like that. Still felt relatively strongly that way after my peds rotation. And then I went through my psych rotation where I kind of, at that time naively didn't realize about a lot of the needs centered around mental health in the community, and really got me interested and motivated into looking into that, especially with how much overlap there is that comes between mental health and any type of primary care or medicine. But, I think I definitely really saw that in the kids and the adolescent population. And so once I saw that overlap, I really then became more interested in that. And from there, I also started developing a little bit more of specified interest in kids who are born with like certain congenital conditions, or kids who have chronic medical illnesses that then have overlapping comorbid mental health concerns. And so that kind of became like a point of interest, and that really shifted my focus towards applying for a combined program like triple board programs. And so when I was looking at different residency programs, I applied to a lot of the categorical psych programs, the adult psych, child psych fast track programs, along with triple board programs. And so I kind of always knew that my focus was gonna be in the kids and the adolescent populations ultimately. And thankfully, going 4 years into residency, that thought has not changed. So that's always reassuring when you start off residency and you still feel strongly and passionate about what I'm doing. I think, and I can talk more about this later in some of the Q&A, but where I'm at in my triple board residency program is that I'm going through my longitudinal outpatient adult psych year. And I still have a little bit of peds and a little bit of peds, and then some more of outpatient child psych to actually complete my training. But as a whole, it's a 5-year residency program, so it does end up getting a little abbreviated. And so we try to pack up a lot in the 5 years. And then I think that's kind of probably the overall gist of things. Ultimately, I'm still looking at like different career options. Doing something like CL in a children's hospital was definitely something that I was interested in when I started the combined program, and I certainly am looking into that as a possibility. I've also been exposed to a lot of different levels of care when it comes to mental health, and I've been particularly interested in something called like day treatment or intensive outpatient partial hospitalization programs for adolescents, and so that's something that I'm keeping in mind as well. I think that's about it from me, Sebastian. I'll hand the reins back to you, I think.
Thank you so much. So last but not least, we have our last panelist, Dr. Fuchs. Or is it Dr. Conroy? No. We had a panelist from the neuropsych program at NYU. Maybe Dr. Fuchs wasn't able to join us, and that's absolutely fine. So I guess we can just go back to our questions. Alan, do you want to take it away?
Yeah, sure. So, hey everyone. We surveyed psych sign and student bodies for a variety of questions, and they had a lot. But why don't we start out with what's in the chat? I think Abrar, sorry, Ibrahim, sorry,
Yeah, Abrar, I don't know if my question is clear, but this is for Dr. Uji. How did you decide? You said you were really interested in peds initially, and then how did you choose to dual apply triple board and psychiatry? What steered you away from dual applying peds? Because that's kind of in the boat that I'm in, and I can't decide between either because there are only 5 triple boards in the program. I just can't decide what to dual apply. And yeah, I guess if you had any advice on that.
Yeah, definitely. I think it comes down to, preference, obviously, I guess. For me, I think when I was getting ready to apply for residency, I knew that ultimately my goal was going to be some type of child and adolescent psychiatry training, whether that was, just categorical psych going into child psych fellowship or triple board, or, there's like the really long way to do it, which is like the post pediatrics program. I'll be honest, the post pediatrics program is ultimately a little longer when you take like the combined years of training, plus it's you have to, I think, reapply for the fellowship. Similarly, when you go through the categorical psych route, you have to reapply for child psych fellowship unless if you get into like one of these fast track programs. And so, that's like a convenience factor for triple board residency, is that the fellowship is included within the residency program. You get exposed to, gen peds and adult psych and child psych. And so you kind of, it's almost like a greedy choice for me, I think, in trying to get all 3. But if I couldn't get into a triple board program, then my sort of next goal was going to be to go through some type of psychiatry training to get into child psych fellowship. And so that was my decision behind choosing to apply psych and triple board as opposed to peds and triple board.
Okay, thank you. That makes sense. I guess just like a quick question about scores, like, is it more competitive? What kind of step 1 and 2 scores do they look to see?
So next year is my chief year. And so I think next year I actually get to look at some of these things. This year I have not been I have still not been super involved with like the nitty gritty of the application process. And so I don't know the exact answer is my honest answer to that. I think what's also difficult is I think things are changing. So they're no longer keeping score of some of the step exams and stuff like that is what I've heard. And so it sounds like it's an ever evolving landscape. And I'm not sure, maybe Dr. Gagliardi, you as a trainee director, you probably have more insight into this than I do.
Yeah, I think the most important characteristic that the vast majority of combined training directors would wish to identify is a passion for that combined pursuit. There are many ways to reflect passion and ability. I would consider failing a board a red flag. And sometimes people fail a board and they're able to explain it in a professional, accountable way, and there's a good reason. And so it's not an automatic out for me. I've seen people with super high board scores have quirks of personality or performance, and I've seen people with what you would consider super low board scores be outstanding physicians. And so I think it's probably fair to say that the vast majority of combined training directors are really seeking to find out who really wants to do this extended, arduous training and how do we get them. I would say the applications are kind of split between a group of those people and a group that we do have to try to figure out. So I would strongly suggest this kind of gets at a different question that was out there, not making it seem like you're applying to me as a backup. So what that means is you didn't start anything related to combined training until August of your application year, or pretty obviously you'd like to go into radiation oncology based on 100% of everything that I see. And the letters of recommendation say radiation oncology too. Like those are also red flags to me, regardless of what your scores are. So I don't think anybody would at this point admit that they use cutoffs for scores, especially with step 1 going pass fail. I have never found cutoffs to be useful or relevant. And so I encourage you to give your best effort learning from your patients and passing these exams that you have. If I were a neurosurgeon, I'd tell you needed to get 270. Otherwise, I wouldn't look at your application, but I would not say that as a med psych person.
Thank you. Thank you so much.
Yeah, I totally agree with everything Dr. Gagliardi said. And I would also offer that, like, unlike a lot of the categorical internal medicine and categorical family medicine, categorical pediatrics residencies, in the combined programs, there's far fewer applicants. And so there's much less of a need to immediately screen by score. Even in the past, when people would do that more commonly, I think at that time, like, the applications were reviewed pretty holistically, and like you wouldn't be like ruled out by a step score in the same way that you could have been in like an internal medicine program. And so that is a nice thing, is that like they'll probably get considered no matter what.
Hi, everyone. So just a quick update. I do think Dr. Fuchs was able to join us.
Yes, I am here. Can you hear and see me?
Yes, we can hear you. So Dr. Fuchs, thank you so much. If you want to just briefly introduce yourself, where you're at, and just give us some pearls of wisdom as to why you decided to pursue the program you're currently in.
Wow, the hot seat. I guess that's what I deserve for showing up 20 minutes late. So I'm Ben Fuchs. I'm a PGY6 in the double board neurology psychiatry residency at NYU. And I love it. I think obviously it's a challenging and long road, 6 years of residency, but here I am, you know, in my 6th year, and if I could do it all over again, I wouldn't do anything different. And I think that speaks for something, because, you know, it's not a small undertaking to sign up for this type of training. Pearls of wisdom. Wow. I think, honestly, if you want to be a brain doctor, and don't like feeling confined to what are somewhat artificial silos of neurology and psychiatry, and you like to feel, you know, facile and comfortable with sort of moving between different lenses of perspective on particular problems. If you sort of value, you know, maintaining multiple different perspectives at the same time, if you enjoy liaising between colleagues in multiple different specialties and speaking a neurologist's language among neurologists, and then converting that into psychiatric language among your psychiatric colleagues, I would strongly consider double board training. It's a lot of fun.
Thanks, Dr. Fuchs. We had some questions that we'll move along with that students were wondering. And on the top of the list, I know each of you have talked about various aspects of the dual training that you take advantage of, but many students are kind of wondering that there's this notion out there that perhaps the dual training won't lead you to practicing necessarily both. And so they were wondering whether, not whether bluntly if it's worth it, but what would you say would it be the advantage of doing this type of training, these dual boarded training, in terms of the specialty practice you might have at the end of the day? Anyone can go.
Well, for the last 2 or 3 decades, people have been talking about the impossibility of insurance paying for both types of encounter in one visit. So this is, you know, a logistical challenge. I have to figure out if I'm billing as an internist or a psychiatrist. At the same time, when I'm rounding on the general medicine service, I can tolerate the distress of the emotions that my patients bring me, and I can be open-minded, curious, non-judgmental, hopefully more therapeutically aligned. And this actually gets to the question that's in the chat. You know, even if I'm on my medicine rotations as a trainee, I'm practicing my cognitive behavioral skills and my motivational interviewing, and the proof is in what the patients do. You know, and so like there's 5 years of exposure to patients instead of 4, which you know, rapport with patients and sort of life perspective are probably in some ways more important than other aspects of what type of psychotherapy you're doing. In terms of limitations during the training, I know Dr. Fuchs just said he wouldn't do anything differently. There are probably little lulls during training. End of 3rd year for me was actually psychologically devastating because all of my bonded internal medicine friends were done with their training. And beginning of 4th year, one of them was supervising me in medicine clinic and going in to check behind me. We were interns together, and I was like, are you kidding me? And 2 of them were hospitalists, and I had to call, you know, them by doctor last name because I'm at a hierarchical institution at the time. And some of them had gone on to fellowships. And so that was a really challenging time. And it's also the nadir of time in a 5-year residency where, like, no matter what you do, you still owe like 2 years. Like you can go to one or the other and you still owe 2 years. So that is probably the psychologically most challenging time in that combined residency training. There's always the anxiety and what some people like to call imposter syndrome. Like you've gone from 6 months of psychiatry and now you're in the intensive care unit of medicine. Like that's pretty anxiety provoking. You're on medicine, you're like, oh, I can't wait till I'm on the cakewalk of psychiatry. And then somebody calls you and they're suicidal and you're like, oh, this is hard too. And so those are like daily liabilities of training. But there are some of these predictable times when you might actually question yourself and wonder, like, why did I do this thing? In most training programs, including mine, we have done things to help you gain a sense of community. So you don't just have loss at the end of 3rd year, and that you have your med psych cohort, and you also gain the psychiatry cohort that you're going to be graduating with. But I would say those are honestly challenging times. And then like after that, 10-year maintenance of certification is another challenging time. So don't take both boards in the same year is my best recommendation for that.
Yeah, and I guess I will add that, like, it sounds like AMP has done like these like surveys and like, you know, looked at this over periods of time. And I think a lot of medical students will ask, you know, like their mentees, their local people that they look to for advice. And there's not a whole lot of people that are combined out there. And so like most of the time they think about medicine and pediatrics as the combined thing that they kind of refer to as their reference point. And it's hard to do medicine and pediatrics at the same time because there's sort of mutually exclusive age ranges. I mean, you could argue that adolescents share like maybe some specialized conditions if you follow them across the life course. But at the end of the day, like with medicine and psychiatry, you can do both of those at the same time, or neurology and psychiatry, or pediatrics and psychiatry. And so it's much more feasible in that way. And it's approximately something like 75% of recent graduates in the last whatever years have gone on to actually do both of those things. It does require helpful mentorship, like that AMP is really integral in getting in order to approach not job negotiations, not with like, who will hire me and like, what could I possibly do, to like going to employers and saying like, I want to do these specific things and telling them what you can be used for rather than letting them use you to do whatever they need. And that really does make a huge difference in terms of like how you get a job. But other benefits and good reasons to do it are like, sure, maybe higher pay, but more than that, you have much more bargaining power because you're much more of like a rare bird. And so you could probably negotiate more effectively for like more time with patients, argue that you're taking care of more complex people and that like you need a little bit more time to do that work and like, you know, be able to do both of those things in the same visit. You could also argue for more flexibility in terms of like how your week is scheduled and laid out, like, you know, whether it's less call or other things. I think that's like up to that individual person. But in an academic facility, especially, it's much more easy to divide up your time, have one department pay the other for your time and sort of like be on like 5 different services in a week rather than spend all of your time doing one thing, which may be necessary in certain situations, but for the most part, like you can kind of make your week, which is really exciting. And that can keep changing over the course of your career too, which is even more exciting.
Okay, if there aren't anyone else wants to add to that, I guess we could move on to our next question. And just the basic, how long is your residency program and what is it like year to year? So I guess Dr. Abraham, you can go ahead for fam med psych, please.
Sure. I mean, to kind of save everyone else a little bit of time, all of the combined residencies other than the neuropsych combined residency, they're all 5 years, and neuropsych is 6 years. And then within psychiatry, there's an ACGME requirement that you have to do like basically a year of continuous outpatient psychiatry. So at some point in all of the programs, they will do a year of outpatient psychiatry, and that usually will have a little bit of, primary care clinic or like whatever else like blended in, so that you're not not fulfilling other ACGME requirements. But other than that, I think for the most part, most programs do their outpatient year during PGY3 or during PGY4. I think of the FM Psych programs, maybe ours is the only one that doesn't do it during PGY4, but ours does it from like sort of September of PGY3 to September of PGY4. So I'm still in that period of time right now, which is a really awesome learning period. Other than that, like the first and second years are mostly 50-50 splits. The fourth year is more family medicine heavy, and the last year is more open with electives. Like we have about 5 electives our last year, which is great. And yeah, it really just depends on the program. It's not really specialty dependent. It's like very program specific. And I would defer to everybody else to kind of explain how that works for their fields.
Yes, I would definitely agree with Dr. Abraham. I can share my screen very briefly to show you. We have a, this is my residency fair thing. So if you end up going to the residency fair, I apologize, you'll have seen this already, but if I can enlarge it, like this is supposed to be our sample schedule, and it's just like he said. So our the first year we have 8 months of medicine and 4 months of psychiatry, so that you cannot be an intern second year. And then it's in 3-month chunks, split evenly between medicine and psychiatry in the second year. We do 8 months medicine, 4 months psychiatry in the third year, so that we can have that 10-month continuity block. It is funny because there are some competing ACGME requirements, which really shouldn't be your worry, but that's why sometimes people start in September and end in September, and sometimes they do things like what we do. And then the last year is 6 months and 6 months. Our residents have medicine clinic all years, continuity medicine clinic, and they start their continuity psychiatry clinic in their third year. I think I had seen a question that might, my residents, if they have met the criteria for categorical medicine moonlighting, may moonlight. And if they've met the criteria for categorical psychiatry moonlighting, may moonlight. Different institutions have different approaches to moonlighting and whether or not it's available and under what parameters.
So I know one of the questions we got was actually surrounding electives and whether or not double trained residents actually get less time in electives. We already covered research time, but is that also the case for electives?
I think if you think about categorical psychiatry training, which used to have a full year of internship in medicine and then 3 years of psychiatry specific requirements, and now only has 4 months of non-psychiatry primary care through in the intern year, you can see that there are already 8 months just built in that are totally free for really whatever elective the program is permitted to give you. Now, some programs have to provide more service than others, but there's just more time built in to a categorical psychiatry residency to give you that elective time, which also makes it feasible for us to crunch it down into 2.5 years of like the absolute requirements. Our residents have elective choice in like which psychotherapy elective they select. They can do ECT as an elective. There's some choice in which consults and ambulatory blocks they do on medicine. They have to do cardiology because that's one of those rules in the combined training requirements. But, if they really want to do a lot of sports medicine or rheumatology or oncology, they have some flexibility in determining those things. I would imagine that's similar in these other programs.
Yeah, I don't know off the top of my head what my total number of elective weeks is over the 6 years and how that compares to the categorical folks, but I do not feel like I am at a loss for opportunity to get elective time should I want it.
Thanks, Dr. Abraham and Dr. Wakimoto for fielding the questions. I believe that's it for the questions in the chat for now. Another question that students asked more generally is how do you find mentors for combined programs at your institution? Is that something that some students have to struggle with? And how do you have any recommendations for that?
I think Dr. Abraham mentioned that a lot of people are going to be at institutions where there isn't combined training. And sometimes you'll actually find people who will say things to you like, why would you sign up for a harder training experience when you could just do 4 years of psychiatry and a fellowship and come out the same? I think we would all posit to you that it's not quite the same, that there's a different kind of integration of the experience that we have as going back and forth rather than focusing on one discipline versus the other. So if you find yourself, and you know, they have legitimate concerns too, but sometimes if they haven't gone through combined training or they don't know combined people, their advice could come from a variety of places. And so I would suggest, I think we had indicated this Association of Medicine and Psychiatry loves medical students and would be very happy to have you join. I think it's a requirement of the mentorship program that you be a member of AMP. It also is one of those things that is probably an easy checkbox on your CV that you belong to the Association of Medicine and Psychiatry, and you stick that on your combined application, and people are like, oh, they care enough to have joined that organization. But I think that's like one way to meet a bunch of combined people. I know that the resident fellow committee of AMP has some slide decks that they're willing to sort of bring to students at institutions where there isn't med psych, kind of like prepare, like, why would you do this? Like, what's it all about? And probably they'd be quite happy to do that. If you reach out to me, I'd try to put you in touch with those people. Unless, Dr. Abraham, are you one of those? Are you an RFM delegate?
I'm not this year. I used to run the mentorship program for AMP between medical students and residents, and I stepped down from that position, like I think January of this year.
Oh, bummer.
But yeah, no, it's a great program. I think they're trying to make sure that like it's more sustainable because we had just like so many medical student requests as compared to like residents who are sort of like engaged in that time period. But I think going back to in-person conferences will really make a big difference for that because it was just sort of like a COVID effect, I think. But that said, yeah, getting connected with AMP is definitely a helpful way to get mentorship. Another really direct way is to do an away rotation if you can. If you can do that during fourth year, it'll like force you to sort of be around combined people like 20 plus, 30 plus people, and you'll be working with them for like an entire month in a row. So you'll really get a good sense of like, do I think like these people? Are these people kind of like my people? Do they think like, are they similar to me? Would I get along with them? All those kinds of questions. And then it really, in interviews, also sets you up to be able to explain like, this is my rationale for doing it. I've seen it, and I know I want to do it, rather than it being sort of this theoretical construct in your head about like, maybe it would be interesting. And so it's not like mandatory, it's not a requirement to do an away rotation. If you can financially afford it and it like makes sense in your like schedule to make that happen, it's definitely an advantage for you more than it is for your application. But it's a very personal decision, and it's also kind of hard to get that set up. There's just not that many of them that do it at the same time.
I think an interesting sort of alternative way of reaching out to program, I don't know about reaching out, but like ways to check out programs that developed during the pandemic is Instagram. I don't want to be the adolescent advocating pediatrician in the room to be saying all these things, but I know that like the Utah Triple Award program, as a shameless plug, like one of my co-residents runs a pretty active like Instagram page that talks about like life as a resident at Utah and like things about like the Triple Award training. And I know that there are other Triple Award residency programs that have like pretty informative and active Instagram pages. And the reason why I bring that up is because I think a few weeks ago, there was like a medical student sort of like Zoom fair for Triple Award programs. I missed it, so I didn't go there. But you know, some of these like info sessions that sporadically pop up will be posted on Instagram. So sometimes like that'll be a good way for people to find out like, oh, there's this cool event happening and I wouldn't have known about it otherwise. And so just as and I personally don't do anything on Instagram, but I'm just, you know, putting that out there. It's kind of a change in the times, I think, with recruitment and so.
And I think that's actually a good point. Like you, some places have young, enthusiastic residents and program directors who are all about social media. I would encourage you not to interpret, and some combined residency programs have their own budgets and some are sort of sharing website space with the categorical programs. And so try very hard not to judge these books by their covers, because there's merit in each and every combined residency program that you'll really learn best about by meeting the people, either by reaching out via email if you have the opportunity to do an away rotation, or meeting people in, you know, a session like this.
Okay, great. And sort of related to an earlier point that was talked about, are there specific fellowships that are popular amongst each of your dual residency training or triple board residency training programs? Like, I guess addiction fellowship was one that was touched on previously. Is there a popular route that people seem to choose based on maybe their training or what they've seen in your programs?
I can speak to the neuropsych ones briefly. Oftentimes, I mean, after 6 years, a lot of people don't feel like doing a fellowship anymore, and I think they're quite entitled to that. I do not plan to do a fellowship myself. And I feel, you know, knock on wood, adequately enough prepared for what might come next without a fellowship. So I'll just sort of say that at the outset. But in terms of the neuropsych sphere, you know, a lot of the fellowships that people, you know, who do them end up choosing are oftentimes neurology fellowships in subspecialty areas with patient populations that typically have a lot of psychiatric comorbidities. So epilepsy is an example of a neurological condition with a lot of psychiatric comorbidity, movement disorders, Parkinson's disease, traumatic brain injury is pretty common. And some folks, you know, multiple sclerosis as well. So that's oftentimes what people look at. But, you know, I would also just reiterate that, you know, at the end of double board or even triple board training, it, you know, is quite common that you'll feel, you know, adequately prepared for what, you know, might come next. And at the same time, if you feel like you want more training for a fellowship, obviously that's always on the table, and you have the breadth of multiple specialties worth the fellowships to choose from. So that's also just a nice thing to bear in mind.
I think if you've met one combined trained physician, you've met one combined trained physician. So probably if there are 10 residents in Dr. Abraham's group, they're all united by a passion for this combined training. And they're all going to do something slightly different with it. So we've had, I think, probably 3 or 4 go through pulmonary critical care fellowship following med psych training. We've had 1 go through infectious disease, 1 go through hematology oncology, 1 go through geriatric psychiatry. And then like a rash of people have seen that med psych is a really great fit for palliative care. And so I think we've had maybe 5 of our graduates in the last decade or so go through palliative care, and some become leaders in palliative care in their institutions. We have somebody who's a medical director of an addictions program in Virginia. I think he got addictions trained after, maybe some years after residency. You can do that through medicine or psychiatry routes.
I guess it's a little bit unfair for me to speak for my program directly, just because I'm in the second class of my program, so this is the first year that we have all 5 slots filled, being a relatively new FM Psych program ourselves. So we haven't had anyone go on to tell you about, but I think out of the 10 people we currently do have, I think I'm the only person who's interested in doing fellowship at this moment. Like other people have said, like it's a long path, and it's totally reasonable to not do fellowship afterwards, and you don't need to. But if you wanted to, I think addiction is nice, partly because it doesn't like limit your scope of practice so much. I kind of worry that if I did child psychiatry, like I had considered doing that, but I just feel like there's such a need for child psychiatry that it would be hard to justify not doing much more than that. And that's part of the reason that triple board makes so much sense, is that you sort of like hone in and focus on that. I considered like some other things, but at the end of the day, it's a very individual and personal decision. So it's hard to say generally like if everyone does it or not, but for the most part, I would say family medicine probably does it less often than internal medicine psychiatry.
Yeah, and I think from our perspective, because child psych is typically a fellowship on its own, and so at the end of our program, we feel like we did our fellowship, and so I think most of us don't pursue further. That being said, I know of I think when I do hear that people go into fellowship, I think I hear a lot in peds palliative care. That's something that comes up quite commonly. And then there's a smattering of triple board graduates who've gone on to do addiction training as well, and try to focus on the niche of like adolescent addiction or substance use population. I think my view of this is probably pretty limited, but I think that's most of what I've heard. And then I mentioned the chat earlier, but like, you know, there are some triple board residents who then decide to pursue like different peds specific subspecialties like peds GI, PICU, that kind of stuff. And I think a lot of that tends to just be like whatever that individual person is passionate for. So.
There's some questions in the chat. Let me see. I think some of them were answered before, like how do you glimpse what might be a combined training like, and you could use social media or try to go to conferences for that. I'm sure there's more you can add for that, but let me see. Sebastian also mentioned some about program size. So a lot of the dual or triple board residency, the program sizes might be a little small. I was wondering if you could kind of comment on that. Does it feel small because you might be a part of both departments, right? Or 3 departments. So it might not feel small in the end, but it might look small. So could each of you comment on that? Let's, I guess, start with Dr. Wakimoto.
Yeah, I think so. Program size, my class had 2 residents per class, and then the year after 2 years after that, we started having 3 residents per class. So we were able to expand, which is nice. So the current PGY2s and PGY1s, there's 3 of them per class. I think Brown and Indiana were the other 2 triple board programs that have 3 residents per class. So that's kind of like the max size so far. And then outside of that, I think most programs have 2 residents per class. Somebody asked about like new triple board programs opening up. I think I did hear rumors about UT Southwestern. I'm honestly not, I don't know 100% about a lot of these. For like the longest time, we kept hearing rumors that like Hawaii was gonna resume their triple board program, but then I don't think that ever came to fruition. So I feel like rumors kind of come and go, and you know, it's always hard to pinpoint what's accurate. I think in terms of like how I feel with the program size, I kind of consider the triple board program to be like, yeah, us as a core, I feel like I have like a close, small group, tight knit, you know, group of people that I like always hang out with. And then I feel like my friend group expands pretty nicely into like my categorical peds residents that I started off with, and the categorical psych residents that I'm also, you know, like most closely associated with. And like Dr. Gagliardi was saying, you know, like my peds co-residents who we started off have gone on to being attendings or applying to fellowship and stuff like that. So it definitely makes you feel a little weird and awkward. But that being said, I feel like it's nice. Like I feel like I have a wide group of friends in different specialties, but I also have like a tighter knit family that I can come back to. So that's how I feel with the program size.
Yeah, I guess I'll say that. So our program is 2 residents per program, and that's what it is for all the FM Psych residencies. So that's it's only 10 residents in our programs combined, but like it's a lot of residents that you like are in training with together. Like we have a relatively large FM program. I know like internal medicine is usually like 50 people a class or something, but we have a 12-person family medicine class, which is large. And then us on top of that is 14 people. There's 8 categorical psych residents per year. So that's like, you know, it's a lot of people times 5. It like ends up being like 110 people to know every year. So it ends up just being like a lot of people that you have to sort of keep track of. And like, I think up until this year, I didn't really have trouble keeping up with like individual people and like feeling like I knew everybody. But this year I was just kind of like, wow, there's a lot of new interns, like yikes. And it is like a really difficult transition to when you're like incoming or when your intern class graduates, right? So like Dr. Kegley already said, like, this is my first year where like my co-interns from family medicine aren't here anymore. Some of my co-interns from psychiatry have fast tracked into child psychiatry or other fellowships. And yeah, it does like kind of get a little bit more lonely as you go on. I would say like the first and second year, I felt like extremely included and extremely part of both classes. And I was like, what do you mean I'm not in that class? I'm definitely in all the classes. But I think as time goes on, you sort of like just feel like things are different, you know? And I think that's a pretty normal part of any residency program.
Would any of our panelists ever recommend for any student to only apply to double or triple board programs? And if the answer is no, how do you recommend that a student balances this tension between I'm interested in double board programs, but maybe also the school's psychiatry or family medicine program? And how do you avoid sort of looking bad, sort of that you're applying to everything, right?
I have strong opinions on this one. Can I take a shot? So I think we would be kind of foolish to think you're only going to apply in combined programs because we know there are a limited number of combined programs. I put in there hooray for new programs because there was a period of time when we weren't permitted to have new programs. The ABPN had a moratorium on combined programs. And so it's great to see new programs. I would say that in our institution, students get so anxious, they way over apply. And that's a problem in all psychiatry specialties, like categorical psychiatrists who are in training directorship worry about it. And those of us in combined training directorship worry about it. Because like, if in psychiatry, they've got 1,400 applications to review for their 11 spots, which has happened. How are they supposed to know who's actually interested in psychiatry and who really wants to be in your program? And so I would encourage you not to go hog wild and just go into debt, applying to as many programs as you possibly can. Really think about what characteristics of geography, lifestyle, and program that you actually value and want to find more out about before you apply. Once you've decided what you're applying in, you should really make the effort to have a separate application for each. One of the main features that I don't think we've yet emphasized, but that I was sort of typing out some answers to some of the questions you had all asked before is, some of the liabilities of combined training. I think all of the residents on would say, like, sometimes you're expected to be in two places at once because somebody didn't pay detail-oriented attention to your schedule the way you would. And if you don't have enough organization to manage sort of two separate applications, that might be challenging. So again, I kind of joked about, a letter of recommendation that says radiation oncology, but when you're soliciting your letters of recommendation, make sure it's clear to the people writing them what you're applying in. I do get a little disconcerted sometimes as an internal medicine psychiatry residency director if I see a letter of recommendation that says somebody is like whole hog into family medicine, because like we don't do babies, we don't do kids, like we don't do pregnant ladies, and so and then I'm kind of stuck wondering, was that sloppiness and I have to worry about it? That's a red flag. Or is it they don't actually want to do my program and I have to worry about it? That's also a red flag. So I think the best way is to and your personal statement would be slightly different. Like why you want to go into combined training is a slightly different answer than why you must be a child psychiatrist, and you don't have to know exactly what you're going to do, but this understanding that it's a longer course, there's sort of this holistic view of patient care. There's something that you see that would be missing in either categorical. Those are things that wouldn't necessarily be things that you would tout in a categorical application.
So we have a question in the chat specifically for Dr. Fuchs. And that question is, what is the scope of practice for someone who is double boarded in neuro and psychiatry? How do you plan to incorporate your training into your clinical practice after residency? And what do you consider the utilization of neuromodulation?
Wow. Yes. I won't have time to give the most thoughtful answer to that very thoughtful set of questions. And I'll say, please do feel free to email me afterwards, because I would be happy to talk more at greater length about this. So when I'm done speaking in this moment, I'll put my email in the chat there for you. But I would say, yeah, neuromodulation is super exciting and amazing. And I've considered sort of using it as a paradigm for thinking about how neurology and psychiatry could be blended, because, you know, sort of like a set of interventional modalities that are employed across the neurological and psychiatric spectrum, be it, you know, electroconvulsive therapy or deep brain stimulation or TMS. You know, these are tools that we use for people with both neurological and psychiatric conditions. So I think if you're interested in neuromodulation specifically, definitely consider double board neurology psychiatry training. I think it's right up that alley. Otherwise, I can, you know, tell you, I mean, in terms of my scope of practice, what I anticipate, I'm currently trying to position myself for a job after residency, a mostly hospital-based position, essentially being like a consultation liaison psychiatrist or embedded neuropsychiatrist to neurology services. I love CL psychiatry, and I love it most when it pertains to the organ system that I care most about, which is the nervous system. So I'm sort of hoping to be basically like a CL psychiatrist for patients with neurological conditions. That's kind of my vibe. But again, you know, neuropsych is cool because you have access to the entire breadth of the training. You could become a psychoanalyst. You could become an interventional neuroradiologist treating strokes, you know, interventionally, right? And literally anything in between the two. So I know I want to be sensitive of everybody's time here, so I will stop there, but I will put my email into the chat, and please do feel free to reach out. I'm always happy to talk at greater length about all this stuff.
Thanks, Dr. Fuchs. I guess just one last broad question is, in each of your training programs, how do you feel residents or embrace the non-psychiatry side of their residency training? Or do you see them more leaning towards psychiatry? I know Dr. Gagliardi mentioned earlier that everyone's sort of different in these programs, but could you kind of speak to that, how residents look at the non-psychiatry part and sort of combine it within their training?
I don't think you'd want to undertake combined training just to get a little expertise in diabetes screening. You know, what you'd want to do in that case is find a psychiatry residency that takes those 4 months of non-psychiatry primary care seriously and maybe has some collaborative or integrated behavioral health care. So generally we find that people are passionate about both and fit in very well, I think, as some of the other panelists had said, with both sets of trainees, and then have the bonus sort of identity, professionalism, accountability set of their combined cohort. So we find that people are fully immersed and fully enthusiastic about, you know, one of my residents who finished last year wants to do outpatient stuff. She was not as eager and enthusiastic about cardiac intensive care unit or, you know, putting central lines in people, but she realized that was part of what she wanted to do in order to be an integrated primary care physician who's able to do the procedures you do in primary care. But I would say, if you're like, oh, like I don't really like what they do in that, I don't feel like myself when I'm doing that kind of work, then I would rethink it. But if you're like, I can't imagine taking care of patients without this other part of training, then I think combined training would be for you.
So with that, I think I want to be respectful of all of our panelists' time. Thank you all so much for joining us. This was a very insightful session. Everyone has sort of included their emails in the chat, so if you do have any questions, feel free to email all of our panelists separately. We're really grateful for everyone's time, and we hope that everyone took a lot out of this session. Thank you all so much.